In the meantime, we're very pleased to have Jean Anderson here. I've already mentioned she is, I think, most of our go-to person for the questions regarding HIV and transmission during and around the time of pregnancy. And it's one of those great examples of how the question remains the same, but the answer changes. And so to give us the current answers, we're very pleased to have Jean here with us from Johns Hopkins.
Thanks, Mike, and I want to thank you all for having Mike give us a break a few minutes ago. Let me see if I can figure out how to do this. Okay. And it's a real pleasure to be here, and I want to thank the organizers for inviting me. These are my financial disclosures, and what I wanted to try to cover briefly in the next 30 minutes is to describe a little bit about the current epidemiology of HIV in pregnancy and the status of prevention of mother-to-child transmission, to talk about where we're missing opportunities, because we really are close to being able to eliminate perinatal transmission, not just prevent it. To talk about something that I think is a little controversial still, and that's the new breastfeeding guidelines for persons living with HIV. And I'm going to say a little bit about pre-exposure prophylaxis in the context of pregnancy, because I think it's underused. So I don't know if these are set up for audience response, but let me just have three quick questions. If they're not set up, I'm just going to read them and just ask for a show up. There they are. So let me go back for a second then. So the first is a 24-year-old woman who's early in pregnancy, 7 weeks. She is on bictegravir, FTC, and TAF. Her CD4 count's 430. She's undetectable. She's tolerating the regimen well. And so what do you do with that regimen in pregnancy? And the options are to continue, to stop all ARVs until she's past the first trimester, then restart that regimen, or change to either a dolutegravir-based regimen or evategravir. Okay. Let's go ahead and show the answers. All right, so the majority of you, and that is the correct answer, would continue our current regimen. We'll go over, hopefully in the next few minutes, some of the slides talk about this a little bit. And this is an example of what Mike said about the questions remaining the same, but the answers changing. The last one, stopping till 14 weeks, were in the original guidelines because of concerns, even with AZT, about first trimester exposure. Second question. This is a 30-year-old woman who also presents in the first trimester, 10 weeks. She is uninfected, but her husband is living with HIV. He's in care, he's on therapy, on ART, but he misses doses occasionally, so she doesn't know about his viral load. So which of the following should be discussed? So PrEP is contraindicated because she's in the first trimester. It's not indicated since he is on ART and pregnancy is a lower risk transmission. PrEP with FTC, TDF and FTC should be considered. PrEP with TAF, FTC should be considered. Okay, let's go ahead and show the answers. Okay. Again, I think this is a very sophisticated audience, but I'm going to say a little bit more about that, but again, I think PrEP is very underused. TAF and FTC are not recommended for persons who are having receptive vaginal sex. We just don't have the data in terms of effectiveness. Okay, one last quick question. 34-year-old woman in her second pregnancy. She is an African immigrant. She did not breastfeed her last baby because, and states that because of that, she really didn't bond with him well. So she intends to breastfeed. She's currently on boosted atazanavir, TDF and FTC, and so which should you consider? Tell her she cannot breastfeed. Consider that that's severe enough concern to call Child Protective Services. Counsel her that breastfeeding is not recommended and say she really has to use formula. Discuss the importance of continuing viral suppression throughout pregnancy and breastfeeding, or recommend that she try to dilute the effects of breast milk with formula. Okay, everybody knows this one, I think. Okay, we can show that. Absolutely, and I'll show you some data about the question of U equals U, or does U equal U with breastfeeding. So a little bit about the EPI. So this is data from a large inpatient database looking at hospital-based live births among women living with HIV and perinatal transmission. From 2010 to 2019, so this is already well into the ART era. And you can see that there are about 3,500 women who deliver each year. You can see that the rate or the number of transmissions has dropped dramatically, and the last data I've seen is that they're under 50. But one thing to consider, this isn't an issue that's going to go away. About 22% of women living with HIV or it's about 22% of all individuals living with HIV who are women, and they are largely over 85% within the childbearing range, and about about a fifth of new infections are among women. This is something that you've probably seen before, and I think that this shows the dramatic progress we've made over the years in reducing or preventing mother-to-child transmission. The baseline rate prior to antiretroviral therapy is around 24.5%. The 076 study was a landmark study which showed that using zidovudine alone cut that by about 2/3, and then it's continued to drop as we've gotten better, more effective, and better tolerated drugs. So in terms of perinatal transmission, in 2019, 84 of individuals had perinatal HIV, and you can see that minorities, particularly Black women, are overrepresented in terms of this. I showed this. I was in London a year ago and went to the Wellcome Collection, and this photograph caught my eye. This is a young woman with perinatal HIV who was, this photograph was taken when she dressed up on the occasion of the 11th anniversary of her mother's death. And I think this is something we hope will be just a photograph of historical value one day. This was prior to effective antiretroviral therapy and prior to effective ways of preventing transmission. So what is the current state of PMTCT? The success of PMTCT is related to, first of all, recommendations for universal testing in pregnancy on an opt-out basis. Secondly is antiretroviral therapy for all pregnant women with HIV, starting prior to conception if possible and without interruption. Scheduled cesarean delivery has a minor role, I think, but it still plays a role with women who are not able to suppress close to delivery. And then appropriate infant ARV prophylaxis, which is covered very, I'm not going to go into those details, but covered well in the perinatal guidelines. And then avoidance of breastfeeding. So in terms of the timing of ART, this is studies both from the French perinatal cohort and from the UK looking at transmission when in women who have an undetectable viral load less than 50 at the time of delivery. And so you can see that in the French perinatal cohort, it's about 0.5%. The UK was even lower. And so while it's low, it's not zero. And that's something we have to inform women about. Now, this is an important slide, and this is looking at if a woman starts antiretroviral therapy prior to pregnancy and continues and then has, you can see the different viral load values, but look at the red box, those who are undetectable with less than 50 copies at the time of delivery. And you can see in the French perinatal cohort, there was zero transmission. And that report has recently been updated and published within the last several months in CID with about double the numbers, and it is still zero. With preconception, starting antiretroviral therapy preconceptionally, and then again, these are non-breastfeeding population. If the woman in the updated data from this cohort, if she has undetectable viral load at delivery but started therapy in pregnancy, then it is still 0.5%. So these are the general principles. We're going to talk a little bit about the use of different drugs in pregnancy. And I think the first bullet point is really important, that pregnancy, lactation, or pregnancy potential should not preclude the use of drug regimens that would be chosen for people who aren't pregnant. Unless there are specific pharmacologic concerns, we'll mention those, or known adverse effects that outweigh the potential benefits. Women who present in pregnancy on regimens that are effective, safe, they're tolerated, should continue on that regimen, and there are very few exceptions. We don't see anymore some of the drugs that are older, like D4T or DDI, that are considered more toxic. Don't discontinue during pregnancy or after pregnancy. Drug resistance testing should be done if a woman is not suppressing, but you don't want to delay starting therapy while you're waiting for drug resistance testing. And then all exposed infants should receive appropriate prophylaxis. We're missing opportunities, though. We no longer have what's called the enhanced perinatal surveillance since 2010. So we're pulling data on where these missed opportunities occur from states that do report to the CDC. And this is data that Steve Nesham from the CDC published about 4 years ago. But if you look at where we're missing opportunities, I think it's as you would expect. Babies who were born with perinatal HIV were much more likely to have been born to mothers who did not have appropriate prenatal care. They were less likely to be exposed to antiretrovirals prenatally, intrapartum, or after delivery, and they were more likely to be breastfed. And furthermore, if you look at when mothers were tested, you can see that the HIV-infected babies were much less likely to be born to mothers who were tested prior to pregnancy, and much more likely that the HIV diagnosis occurred at or after pregnancy. And even though the recommendations have been out there for some time to universally test for HIV in pregnancy, the range has really not exceeded about 3/4 of those since 2006. Note also that from 7 to 18% of infants with perinatal HIV are born to women who become HIV infected in pregnancy, and we'll say a little bit more about that. This is from our own institution, and missed opportunities in the 12 months preceding HIV diagnosis in pregnancy. This is a retrospective cohort of 478 patients. Of those, a fifth were diagnosed first during pregnancy. But when we looked more into their background, almost a half had a history of substance use, a little bit over a half had one or more prior sexually transmitted infections, and 50% with a new diagnosis had a clinical encounter in the year before diagnosis. So there was really a missed opportunity to identify HIV. I'm not going to belabor this slide. I think when you look at lack of viral suppression in pregnancy, it's the same as for other people. Still, adherence issues are the biggest reason for lack of viral suppression. But acute infection is a real problem, and it may account for a major part of residual transmission that we're seeing. Pregnancy is actually a time of increased risk for HIV acquisition, even accounting for or controlling for sexual behavior. And of course, if someone is tested earlier in pregnancy and they're negative and then they're not tested again, then they're not going to be diagnosed. But they're also, as we know, with the natural history of acute HIV, they have a very high viral load initially, and that is a direct correlate to the risk of transmission. So I think that we're moving towards, CDC has recommendations for third trimester rescreening, and they go into jurisdictional incidents and risk factors, but I think that really what a lot of people are talking about now is it should become routine, just like we're testing for syphilis. So let me talk about just the current recommendations, and just so that you know how the preferred and the alternative, which are the main categories of use of specific agents in pregnancy. If it's preferred, it means they've been shown to be effective and safe and tolerable in clinical trials in adults, because these trials have not been done in pregnant women, that we do have pregnancy-specific pharmacokinetic data. It's a favorable risk-benefit ratio, and there's acceptable safety outcomes. Alternative is pretty much the same, it's just that you don't have as much data. And so what you see, if you follow the guidelines over time, is those that are alternative tend to migrate towards preferred. And preferred, some of the regimens tend to migrate backwards as you have better tolerated safety, better safety profiles, and easier to take regimens. Insufficient data simply means that there are certain drugs that are not recommended except in special circumstances, and then not recommended if they are not as efficacious or related to PK data. And so it's really a balancing act, and we don't have a lot of data often to make recommendations. But it's really balancing the benefit of maternal treatment versus the risk of adverse effects. As I mentioned, efficacy data is generally established from trials in non-pregnant adults. PK data is important because of some of the physiologic changes in later pregnancy, in the second and third trimester, with increased plasma volume and some metabolic changes in terms of hepatic and renal excretion. And then safety data generally comes from registries or observational cohorts. Animal data is not very predictive, even though it's often used early in our deliberations about certain drugs. It's not very predictive of defects in humans. And just to give you a very brief overview, if you look at very early exposure, so this is in the first 2.5 weeks post-fertilization, so usually when someone's maybe just missed their period, this is the pre-major organogenesis time period in pregnancy. We don't know really about the sensitivity to teratogens at that time, and a lot of times, at least I was taught, this is kind of an all or none phenomenon. It's probably not going to cause a problem. If it does, it's going to cause a pregnancy loss. This is the period where we worry the most, and it's about 3 to 8 weeks post-fertilization. Remember, that means that's about, you add on 2 weeks for the last menstrual period. And this is the obvious example that we've worried about a lot in recent years is neural tube defects. And the neural tube closes at 28 weeks post-conception, or about 6 weeks after the last menstrual period. After that, you shouldn't really have to worry too much about that. And then after this period of time, there is continued fetal development, obviously, brain development, growth, but the major organs have formed. But you still can have defects, for example, with alcohol use or smoking causing intrauterine growth restriction. So these are actually not published yet. I got special permission from the leaders of the guidelines panel to talk about some of the newer things that are going to be in the new iteration of the guidelines when they're published. I'm not going to talk about all of these, but I wanted to highlight the ones that are in yellow, and also to highlight the situation-specific considerations. So you have someone who is pregnant, who's never been on therapy before, somebody who's on therapy, it's working well, it's tolerated, somebody who's maybe been on therapy in the past but's restarting. They're on therapy now that's not working or is not tolerated, and then they're not pregnant but they are trying to conceive. And so I think some of the big changes is bictegravir has moved from insufficient data to alternative. So it is a very reasonable regimen to use in and certainly to continue in a woman who's pregnant. Boosted darunavir, ritonavir-boosted darunavir has moved actually from preferred backwards, just related to the fact that PK data, this needs to be given twice a day. So it's no longer considered preferred, it's still a reasonable alternative, and it is the recommended alternative if someone gets pregnant after a failure of being on PrEP with cabotegravir. And lopinavir is no longer recommended except in special circumstances. There are no changes in the NNRTIs or the NRTIs. And I think in general, I think the fact that bottom line is if someone comes into pregnancy, they're doing well, they're suppressed, in most cases you're going to continue that regimen, though in some cases you may need to watch it a little bit more carefully. We don't have much data on the entry attachment fusion and capsid inhibitor drugs. If someone gets pregnant on these drugs, then you may want to continue it, but need to be watched a little bit closer with more close viral load monitoring. We also don't have any data on true drug regimens during pregnancy or with long-acting CAB and rilpivirine. So they're not recommended in naive patients, but again, if someone gets pregnant on one of these regimens, you may consider continuing it with more frequent viral load. I'm not going to go over these in general or specifically, but these are the major drugs for which there are PK issues, particularly in late pregnancy, and that if they would not be the first choice to use. All the COBE boosted PIs result in lower drug levels late in pregnancy and have been shown to be associated with some viral rebound. I mentioned darunavir, ritonavir requires twice daily dosing in pregnancy. Rilpivirine, you just have a highly variable PK. So again, if somebody is on one of these regimens and continues on these regimens, they need to have their viral load checked a little bit more frequently. I want to just briefly address 3 drugs for which there's been a lot of controversy over the last several years. One is dolutegravir, and the early signal that suggested there was an increase in neural tube defects with early exposure. The most recent data is very reassuring, and the incidence of neural tube defects has now declined and doesn't to equal related to other exposure groups. And this was from the VESTED trial, looking, just confirming in pregnancy that the dolutegravir containing groups had the best virologic outcomes in terms of both intention to treat and protocol analysis. This is very busy, but the bottom line is that when you looked at dolutegravir compared to a number of other current ART regimens in the US, and this is from the pediatric AIDS cohort, and you looked at some adverse pregnancy outcomes, specifically preterm birth, small for gestational age, and low birth weight, that they were that there was not any difference among the pregnancy exposure groups, and that the adverse outcomes were higher among those who started therapy in pregnancy than those who were already on. So another argument for being on therapy prior to pregnancy. I think we're going to hear, we've already heard some about dolutegravir and weight gain. This was also from the VESTED trial, but that the weight gain compared to efavirenz was higher, as you would expect, but actually most pregnant women were below the recommended target weight gain, and adverse pregnancy outcomes were associated with low weight gain. Bictegravir, F and TAF, this is data from Gilead, 33 women, 100% of those had a viral load less than 50 at the time of delivery. And when they looked at PK data, they did have lower PK, lower concentrations in the second and third trimesters compared to postpartum. But when they looked closer and looked at the unbound, which is the more active part of the drug, those were similar. And again, it did not affect viral suppression. And this is from IMPACT, and also looked the same and found the same thing, that the PK varied. It was lower in the second and third trimester, but it still was, there was no difference in viral load suppression, and still the peak was above the effective concentration for 95%. CAB PK in pregnancy appears to be similar to non-pregnant women. And this is a study that looked at CAB for PrEP, and then you can see that a number of women became pregnant on CAB as well as on oral PrEP with FTC and TDF, and there were no birth defects noted in either study arm. Again, it's fairly small numbers, but reassuring. So let me just go to some quick takes. I've already mentioned about perinatally acquired HIV. They are a challenge, these young women who have lived with HIV all their lives and have usually had extensive ART experience, often with suboptimal regimens, so they have a high rate of drug resistance. So they're more likely to have non-suppressed viral load and lower CD4 count in delivery, and poor retention and care postpartum. So that is challenging. I've already mentioned acute HIV. I'm not going to belabor that in the interest of time. We talk a lot about syndemics these days. One of the syndemics I want to call your attention to is intimate partner violence and depression. And along with HIV, women with HIV are more likely to have clinical depression. They are more likely to suffer intimate partner violence. And these situations tend to be increased in pregnancy. So it's really important to both screen and for depression and for violence, and then to manage it appropriately. I'm going to skip to the bottom line regarding breastfeeding. I think again, it's a balance. We know that in high-resource areas, we have safe and affordable feeding alternatives, safe water. So why breastfeed? We also know that we have differential penetration of different drugs in breast milk, which may not be an issue, but it is an issue if the baby gets infected, because they are more likely to have resistance. We don't have a lot of safety data for breastfeeding. We know that plasma viral load and breast viral load don't always correlate, and that breast milk cell-associated virus is less affected by ART, but it's important in early transmission. But on the other hand, we have low-resource areas within the U.S. We have a lot of women who come from countries where there is greater stigma, and they would be stigmatized if they did not breastfeed, and that might inadvertently disclose their status. And we know that there are many known benefits. So here's the bottom line. U does not totally equals U for breastfeeding. But if you define undetectable as less than 50, if you start ART prior to conception and you plan pregnancy and you continue having viral suppression throughout pregnancy and breastfeeding, then the risk is very low, less than 1%. So it's not zero for a lot of reasons, but it's very low. So I think non-judgmental counseling is really the key. I'm going to talk about more of this in my breakout session this afternoon, so I'm going to skip over that. But I do want to point out that PrEP coverage is alarmingly low in women who could benefit from PrEP in the U.S. Only about 10% is it prescribed. And this just shows that if PrEP is initiated in pregnancy, just like concerns with ART in pregnancy, there is a concerning drop-off in adherence after delivery. Both FTC and TDF and CAB can be used during pregnancy and breastfeeding. It's safe. Again, TAF should not be used. So just the key take-home points: optimize ART regimens prior to pregnancy whenever possible. Don't say you can't use something because a woman is pregnant or trying to become pregnant. Don't interrupt or discontinue ART during pregnancy. Keep in mind PK issues, that some regimens, if they are used, need to have more closely viral monitoring. Dolutegravir is safe. Bictegravir the data is very reassuring. And I think when women with extensive ART experience, when you see them and they get pregnant, the first thing you should always do is forget that they're pregnant, to think about what are your options, and then add on consideration of pregnancy. I've already mentioned that the specific recommendations tend to migrate as we get more experience. Remember the difference between absence of data and evidence of harm. And then we still have missed opportunities for preventing perinatal transmission. And these are just some ongoing guidance. Thank you.
Great. Wonderful. We have a number of questions. I'm sure some folks will go to the microphone. One question that comes up is if you have a serodiscordant couple where the male partner is positive and suppressed fully and remains that way, and the female partner is negative and they want to get pregnant, is there any reason that you can see to use PrEP in the seronegative woman?
I think that's a situation is kind of shared decision making. You talk with her. Does she know that he's suppressed? Does he miss doses? Is he suppressed consistently? I think it is a reasonable decision to use PrEP if there's any question about those
Right,
things.
but if there's not a question, there's not necessarily a
Exactly.
reason. Okay, good.
Yes.
Let's go to the microphone.
Hi, Laura, Marcellus, Texas. I have a question and a comment. So my question is, you show that the reproductive levels decrease during pregnancy. We are putting more and more women for several reasons on Cabenova, which it includes reproductive, and my question is, do they get affected as well? And then my comment is that for everybody, I still see in charts that people are not documenting reproductive status. It's very hard to track in cohort studies, but preconception counseling starts. Prevention of mother-to-child transmission starts with preconception counseling, and we should all document, if the woman or the man wants to have a baby. So that's my comment.
I couldn't agree more. And again, I'm going to talk at the breakout session this afternoon about the whole pregnancy continuum, which starts before pregnancy. We need to be talking about all who have pregnancy potential, about their plans and their desires. So the question about Ripivirine, we still don't have enough data on CAB with Ripivirine. And it wouldn't be, I think that it's not recommended in general at this point in time because of the lack of data. But if somebody comes in, they're doing well, they're well suppressed, an option is to keep them on that versus switching them, but to follow their viral load more carefully. So when I say more carefully, it's probably every 1 to 2 months. The Ripivirine PK data, it kind of bounces around, and in some drugs, they've looked at higher doses. They have it in Ripivirine, so we just don't have the data yet.
Hi, Carmen Zorrilla from San Juan, Puerto Rico. Good to see you again.
Good to see you.
Thank you so much for this presentation. I have 2 comments. We observed some years ago 2 seroconversions during pregnancy in our setting. So from then we started PrEP in pregnant women, and we publish our information, and we haven't had any more seroconversions so far. Of course, limited numbers, but I think it's a very important message. We have had difficulties finding the medications, having insurance issues with PrEP for pregnant women, and so we have to work around the system to actually get the medication to some women. My other point is about breastfeeding for women for persons with the diagnosis of HIV. Certainly this requires a good communication with your patient, but if they are making that decision of breastfeeding, and I know it was in one of your slides, it has to be absolute breastfeeding, cannot mix, because then you have increased risk of transmission if you mix breast milk with other intakes. So women need to make sure that if they are going to engage in breastfeeding, it has to be full, and that's very difficult in many places as well.
Yes, thank you, because I sped through some of the last slides in the interest of time, but yes, exclusive breastfeeding for at least 6 months, and then start adding in things. Rapid weaning is over a few days, is not recommended, so it's really important. And I think the other point that you reminded me to make is I think that we have a real opportunity in pregnancy to test partners, to get partners tested, and to find new infections that need to access care and treatment, but also to better identify women who could benefit from PrEP.
Okay, a lot of questions. We'll get to as many as we can. Is there a preferred oral ARV regimen for a woman who's breastfeeding? In other words, is there something that, I'll take it the other way, is there something that you shouldn't use in that setting in terms of the baby?
No, I think that, you know, the drugs, we have some information on drugs and how they get into breast milk. The NRTIs get in the best, the INSTIs and the protease inhibitors and NRTIs have less diffusion. And we have just pretty limited information about safety, but we do have better safety information on exposure of the fetus. So I would say no, that the recommendations would really be unchanged.
Okay. This may have been danced around a little bit, but what about for a mom who you're less sure about ability to remain suppressed, she's breastfeeding or needs to breastfeed because of other circumstances, is there any role of PrEP in the infant?
Well, that's an interesting question.
Maybe?
Maybe. Yeah, I think in general, for a woman who's breastfeeding, and if the woman is on an effective regimen, the baby doesn't need to be on extended prophylaxis. But if there are concerns about that, the first thing I would do is say you probably need to switch to formula. I mean, that would be the preferred. If she cannot maintain access to care and good adherence so that she can maintain a viral suppression, she really shouldn't be breastfeeding. I mean, that's going to significantly increase her risk. In a situation like that, if for whatever reason the decision was made to continue breastfeeding, then yes, I would probably do extended infant prophylaxis.
I think this is a continuation, although in a different direction. When is breastfeeding a shared decision versus not recommended?
I think
We're almost out of time, so you will get you on.
I think it always needs to be a shared decision.
Sure.
And I think it needs to be addressed early in pregnancy, not waiting until she's at delivery. And what we do in our program is we ask about it often, and 'cause sometimes the answers change. And for those who decide that they want to breastfeed, we consult with them. We bring together our pediatric infectious disease specialists, our neonatologists, OBGYN, and we meet with them and just go through the situation. And sometimes they change their mind. Sometimes we just give them tools to do it safely. You know, somebody who works and has trouble, you know, saying, I can't take my medicine. So we talk about all the different issues. But I think it really does need to be a shared decision.
Yeah. This is under the assumption that once you start therapy, it's successful, the viral load suppressed and maintained. What is the risk of transmission when starting ART in the first, second, or third trimester? In other words, how much happens before you get going?
Well, I mean, it goes up each trimester. So for I think the French perinatal cohort has the best data, and it was about 0.5%. This is assuming that there's viral suppression at delivery, but starting in the first trimester. And then it goes up from there. I don't remember their numbers exactly, but it goes up. And that obviously also relates to, were they able to reach viral suppression? So what did they start out with?
Right. If I remember from the older days, most transmission, there's not as much in the first trimester, right? That it's later, usually third trimester, assuming untreated.
Yes.
Okay. And then this one's just about the UK. Why is the mother-to-child transmission so much lower in the UK? Is that?
Than here?
Mm-hmm.
Well, I'm not sure I have the answer to that. I think that, I think it is, I don't know the different factors that might be involved. I think, again, we are seeing significant transmission in women who are becoming infected during pregnancy, and who aren't tested, so they don't know they're infected. I would say that those are probably, I think we do a fairly good job once they are known to be infected, getting them on good therapy.
Right, right. Well, last question right here. Yes.
Yeah, hi, Christina Bruda. I work at the NCCC's perinatal HIV hotline, so we really welcome these questions, and we get lots and lots of situations where people are, providers are uncomfortable talking about breastfeeding with their patients and those who are really into it. So couple comments. Number one, infant prophylaxis can continue during breastfeeding, even in the setting, even when mom is suppressed, and even though the data are still not clear that there's added benefit, it's another, like belts and suspenders, right? And then the other thing is that why it's so important to open this discussion up early is because the last thing you want is for a mom to breastfeed and you don't know anything about it and there's no monitoring happening, because they should, both moms providers and babies providers need to be communicating with each other to make sure that both mom and baby are being monitored nucleic acid testing wise. Thank you.
Thank you.
Thank you.
Okay, that'll wrap it up. And here are some questions for your session that we didn't get to.